McKinsey, we did a project in Botswana to launch the strategy for Botswana to launch this HIV treatment program.
We're ready to get underway.
Refers to that.
And we certainly want to make the most of the very short 60 minutes we have with such an illustrious panel. I think our biggest challenge is not going to be the number of ideas that will come out of this discussion, but more the time management. But I'm reassured because we're in Switzerland, and Switzerland is a place of punctuality. My name is Sushant Balakurti-Rao. I'm the Managing Director for Global External Relations with Agility. And as a quick background, it was on this same stage and in this exact same dome last year that we were very proud to have hosted a session with our partner Bexa on achieving transformation in women's health. And subsequent to the panel we had last year, we were very motivated and inspired by the resonance and the feedback that we got from a wide range of partners. And that included, of course, the health sector, but also other industry sectors, policymakers, civil society, who all want to be a part of a coalition looking at all kinds of structural and intangible barriers that inhibit access to health. And we at Agility include ourselves in that coalition, given the increasing investments we're making in technologies and innovations, which we feel, as we put it, will democratize access to health. So coming to our truly remarkable panel that we have today, and experts with me on the stage, we're not only going to hear about the work they're doing, but we also want to hear about the big game-changing ideas that they think will help to push the needle forward, and the ways in which they hope to collaborate with you, members of the audience, or other participants here at the World Economic Forum. And I want to assure you that we don't plan for this to be a monologue of the panel speaking to the audience. We will come to you after 2 rounds of interventions for questions so that we can have an interactive discussion. I'm humbled to share the stage with Emanuele Capobianco, the Chief Strategy and Impact Officer of the WHO Foundation, with Ernest Darkoh, the founding partner of BroadReach Group, with Dr. Monique Gary, the Chief Medical Officer of Bexa, with Temie Giwa-Tubosun, who is the founder of Lifebank from Nigeria, with Dr. Megan Ann Greenfield, a partner with the McKinsey Health Institute, and Dr. Lutz Hegemann, who's the President of Global Health and Sustainability at Novartis. So, Megan, I'd like to start with you for 2 reasons. Firstly, you've led a lot of research and thought leadership on DEI throughout your career, and you've extended that into studies of biases that lead to a disproportionate impact, a negative impact on women's health. And I know you're a data-crazy partner, and keep in mind that without data, we don't have a baseline from which we can actually measure progress. This morning was a very exciting morning because of a tremendous amount of work that went in to a report published in collaboration with the World Economic Forum on women's health. And I remember you describing it as a massive report. So I think that has created now enough suspense for the audience to hear a little bit about some of the key findings that came out of that report.
Absolutely. So we were very excited to launch today, Closing the Gender Gap, a $1 trillion opportunity. And by the way, that's an underestimate. We just don't have data to demonstrate it's higher. And what we look at is the first comprehensive, bringing everything together to size what is the economic opportunity and what is the lives and livelihoods that are at stake by closing this gap. We can add 7 days of good health to every woman worldwide by closing this gap. 75 million years of life annually. That is really phenomenal. And what we found is that there's tons of opportunity, starting with data. We really don't have good data. For example, you take endometriosis, one of the most common conditions that women face. At least 1 in 10 women have it. For example, I just came from a lunch where we launched it. In my own table, 50% of the women had endometriosis. And what is the average time for someone to get diagnosed with this excruciatingly painful disease? It's over 10 years, and you could see that in our table. It went from anywhere from 10, 15, 30, 35 years.
Wow.
So by the time some of these women were actually getting diagnosed, they were already starting perimenopause with many complications that resulted from this. This is just one example, but actually if you look at the data, which is what we use to invest and make investments, right, in health, it's dramatically underrepresented in some of the gold standard data. In fact, 800% at least is it underrepresented in the IHME data. So when people are looking at making interventions, they are underestimating the market potential here, and we know it's even larger. So you take this across. Clinical trials, for example. We did this research is based on 650 academic papers. We looked at the actual performance. Only 50% of them show sex-specific results. Of those, 2/3 of them show that women have worse outcomes than men. 10% men have worse outcomes, and the rest, it's neutral. So all the data suggests, and now what does the other 50% say? And what we found is if you look at all of this data, we need to change our paradigm. Historically, it has been that everything is around human health is men health, and women are just smaller men. But actually, the data we find that over 56%, and it would be higher if we had enough data on some other conditions, 56% of diseases that make the health burden for women, there are differences. They affect women differently or disproportionately. So the fundamental paradigm is we're not actually focusing on human health. We need to think about male health and female health separately, because that is actually what should be the baseline. It's not the exception. And what we find as well, women spend 25% more of their life in poor health. And a lot of people say, oh, but that's when they're old and they don't contribute to society. And that is actually inaccurate. And so if you actually do the math, and that's where we got the 1 trillion opportunity from the GDP, it is actually in their prime working years, from the age of 20 to 60, is where the majority of actually this disability plays out. And this limits their ability to work. It limits their ability to do caregiving. And then they also have to take on that extra burden for the people, their family that is also sick. So unbelievable opportunity. The case for change is clear, and we're setting up, there's a big alliance that's being launched today to take this, take action. So very excited to launch it, and we would love your support in mobilizing to close the gap.
Megan, I almost feel like we need to say thank you because the statistics are truly staggering, and I almost feel as the audience probably thinks I need to digest that and get a hand on the report to have a look at it. So it will be publicly available.
It is available right now.
So it is available on the website. You know, hearing you speak, I'm thinking about all the ways in which you're closing gaps in data, and hearing Ernest speak and having seen him over the years, I found it truly fascinating to see how you're closing another kind of gap, which is that between ideas and execution. Right. And I could sense a degree of frustration that you found when you went to different ministries of health across Africa and actually discovered that there are ideas there in the drawer, but they're not ones, I think, as you put it, that you can on a Monday morning come into the ministry and actually implement. So that's another kind of gap, I think, that you're working in. And I felt, hearing you, you want to push the reset button. So maybe could you share with us what that reset button in transforming health systems is about?
Sure. Yeah, so thank you for that lead-in. I've been implementing healthcare delivery programs on the ground for the last 25 years. And I mean actually delivering, doctors, nurses, in clinics, working with government to roll out large-scale programming. And I think my biggest frustration over the last 25 years has been just seeing African governments in particular doubling and tripling down on a model that has no chance in hell of ever working, right? And just to give you a benchmark, for the last 20 or so years, I always do this back of the envelope. And I don't know if it still holds exactly true right now, but it should be relatively close. If you took all of the healthcare workers in Africa at the moment, a continent of 1.3 billion people, and put them in Kenya, right? Just Kenya. Then Kenya will have the staffing ratios of Canada. Okay? And meaning Kenya has now the pleasure of dealing with the health challenges that Canada is dealing with. Right? It's not like Canada can say we're fine and we're sorted, right? So when you're looking at that and we say, well, our answer is we're going to train enough doctors, train enough nurses, build enough hospitals and facilities to address this, it is completely, ridiculous. So for me, the big frustration is that we keep on doubling down on this model that it just will not work. So what is required if we're actually going to close this gap, these crazy gaps in Africa, is innovation. We have the biggest health burdens of disease, the biggest gaps in resources. It means Africa needs to be the most innovative continent on the planet, right? However, it leads me to my second point. Africa is not innovating at the forefront. My experience has been, again, we seem to be comfortable taking, again, the back seat. Let others innovate. We hope that people from outside are going to come with ideas to basically save us when these are people who do not have our problems. Right? So take the United States, for example. South Africa alone, population 60 million, has 8 million people with HIV. USA, 350 million? 1 million people with HIV. So 8 times the amount of HIV in the US, right? And we're going to hope that model is somehow going to work for us. So that not being at the forefront of innovation, and in fact lagging, coming up with policies that are actually kneecapping innovation before it even can flourish, and yet that is what's supposed to save us. That's another big frustration. My final point of frustration is there's a fallacy, and this fallacy comes under the rubric of sustainability, that government is going to create the sustainability. Government will do it all. And where this is, and when you look at the fact that stewardship of the majority of the bottom of the pyramid populations is under government, and let's say you want to roll out innovative programs, and you say government therefore becomes the one gatekeeper. So government becomes, ironically, right, the regulator, the policymaker, the single customer, right, the implementer, and increasingly now the government saying we'll build those solutions ourselves. So actually the producer of tech, right? That is absolutely not going to work. So to me, those are the things that the frustrations sort of I've run into. And I do believe to provide health care and in a way that's manageable and sustainable, and not just disease care, but truly health care, because we're not addressing the social determinants of health, the tap is on full blast, right? So the demand is grossly outcompeting any capacity we have to actually address it. So we need a hard reset in terms of being really bold and thinking about how we approach things differently.
No, thank you very much, Ernest. And by having sustainability as your third point, it actually leads me to the question I wanted to pose to Lutz. Coming into this World Economic Forum, we're quite on the heels of a COP28 meeting that took place in the United Arab Emirates at the end of November and early December. And Lutz, it was interesting to see that for the first time at a COP meeting, an entire day was dedicated to raising the visibility between the inextricable links between climate change and health inequities. And the WHO estimates that between 2030 and 2050, that climate change could lead to anywhere between 250,000 to 350,000 additional deaths per year. That also is a staggering statistic. Can you tell us a little bit about, from your view, what you see about climate change and how that is exacerbating health inequities?
No, absolutely. And I think it is sort of telling that it took 28 COPs before the link between climate and health was being realized. And I think the more we look into the data, and there's loads of data out there, and the more you read, the more scared you actually get about the situation. There's an excellent Lancet report that summarizes pretty much all the evidence that exists. And I think it's fair to say that human health will become the face of climate change, because really what happens in the environment around us has an impact on all of us and on our health and well-being. What I've seen in recent years, and building on all your frustrations, frustrated me a little bit, was that people got so excited in describing the problem or admiring the issue and not answering the question, and so what? And I think that is where we really need to focus the dialogue on. And I believe that the healthcare sector and the pharmaceutical companies can do a lot in order to mitigate climate change, but also in order to help with the adaptation towards climate change. And let me spend a few minutes to elaborate on that. I think we all know that the health sector itself is contributing to the climate change. About 5% of the global greenhouse gases are attributable to the health sector, not just the pharmaceutical industry. Tertiary care centers are a huge polluter, notwithstanding all the tremendous benefits they deliver. But I think we have to find ways to deliver health care with much less of an environmental footprint. So the pharmaceutical industry certainly, and many companies, including our own, have defined ambitious targets for greenhouse gas remission. Novartis has a 2040 net zero commitment and a very clear path that leads to it. But it's not just greenhouse gas, it's land use, it's waste, it's water, and we need to holistically see that we have a very clear plan to reduce the burden here. But ultimately that is not defining our contribution to climate change, but that needs to come through our core strengths, and that is the innovation, the scientific advancement that we can bring, and the access commitment that should always come with any innovation that we produce. And here specifically, we need to refocus again on infectious diseases. When you read the news, I mean, malaria is now being reintroduced in the United States. You have dengue fever in the suburbs of Paris. You see sort of infectious diseases re-entering countries and geographies where we felt many years ago that we had successfully eliminated them. So I think we need to make sure that we are not trying to address tomorrow's problems with yesterday's tools, but continue to innovate, for instance, in malaria, in leishmaniasis, dengue, and so forth. And those diseases are still heavily underfunded. There was a positive sign at the last COP of the 777. I'm not sure if that's coincidence or if that was a nice way to present a number that people can remember, investment with the UAE and the Bill and Melinda Gates Foundation, again into neglected tropical diseases. That's one element. The other element is the resilience of health systems that we built. And here, I think we need to really consider how can we build, particularly in developing countries, health systems that can withstand the future challenges, whether that is climate crisis, climate-induced migration, involuntary migration, whether that is potentially geopolitical issues. If we bring healthcare into the communities and to the patients, rather than building health systems that we ask the patients to get to, then we'll be building in this resilience. I think that's a very important element that we need to consider as well. So I'm hopeful that maybe through the trigger of climate change, we can address or we can devise benefits and solutions that also position the world for better healthcare and for more equitable healthcare in other areas that may threaten the progress that we have seen in global health in recent years.
No, thank you, Lutz. And I think it's very important to, even if it's not a new issue, to remind ourselves that the linkage between climate change and health equity is very real. And therefore, it's important to have a coalition of leaders working on ways to address those impacts. Monique, it was interesting that Megan started us off speaking about a report. And some of you may have heard that the IMF at the beginning of this week launched a report in which they spoke about the possible inequities that will come about through artificial intelligence. And it perhaps is reflective of a trend around certain issues of distrust around technology. Amongst the many hats that you wear professionally, one of them is as the Chief Medical Officer of Bexa, and part of that is in a belief that technology is something that can tackle inequities, but there's a trust angle to it as well too. So can you tell us a little bit in your work how you see that reconciliation between fear and inequity and trust?
Well, thank you for the question and the opportunity to be here on this distinguished panel. The issues of trust certainly are present here and pervasive throughout the clinical work that I do as a breast surgical oncologist, and whether it is at the patient level, whether it is at the system level, at the community level. And we've heard some pretty sobering statistics regarding the inequity that continues to spread among women who perhaps don't believe that the health system is in fact for them. And how can we then build and bridge that trust when we look at things like NIH funding, that's 11% is allotted to women's health and research related to women. When we look at the issues of things like access and adoption, those are in some ways related to the trust relationship that women have. In the United States, where women may have access, they don't necessarily trust that the innovation is for them. And I'll give you a great example. My grandmother was diagnosed with a cancer that's considered the ghost of breast cancers, lobular cancer. And the innovation failed her. It did not find her cancer. And so how do we trust in innovation for early detection? I spoke with a physician recently who said, I know all the data. I see patients every day. I recommend they get their mammograms, but I don't like the science, I don't like the technology, I don't like the experience, and I don't trust that it's truly in my best interest when I get my results in a portal on my phone and I find that I have cancer on my phone. So my trust in this health system it's diminished. And so at Bexa, I think we really have solved one of the fundamental issues before you can even address the issues of tech and AI across a digital divide, which is, do women feel heard? Do they feel seen, and do they believe that technology is adaptive and adapting to their needs, to their comfort, to their wishes, and to their overall health? Will we find the things that are important for them? And so we started by listening to women. And for the men in this audience, if you have a wife, you know there's nothing that makes her more upset than believing, whether true or perceived, that she's not being heard. And so we listen to women. And what they say is, we want a technology that is accessible to us, that is affordable, that is painless, that is radiation-free. And so we've begun to really craft a care delivery model, not just a product, but an entire service that addresses that trust gap. And building from there, women come, and they come again, and they come again, and they now have forged a trusting relationship. And the last thing I'll say, is that the trust relationship certainly extends to the private and public partnerships. Because it's not just do our consumers or our patients, but before patients, they are consumers, they are clients, they are customers. Not just do they trust in the innovation, but do our corporate partners trust in the innovation and the relationship? Do our policymakers trust in innovation and this relationship when 30 to 39-year-old women are the fastest growing demographic for breast cancer? So there's a cognitive dissonance and a little bit of an apathy, I think, that does not contribute to the trust relationship. And if we are going to have an honest conversation, we should be honest about that. And it should be that in women's health, women must feel heard and must feel represented. And then subsequently, our discussions surrounding that must develop tools that work for them.
No, thank you, Monique. And also, thank you for mentioning your mother, because I think that underscores the fact that trust is something very personal.
Indeed.
It's our mothers, our sisters, our grandparents, friends, neighbors, and it's important not to lose sight of that linkage, the very personal dimension. And Temie, I think that's a great segue to you, because your story, your life work is also very personal, and it's very inspiring, because you chose not to accept that there is a, let's say, deficiency in supply and demand in blood transfusions in Nigeria, and in a way that it's actually very fixable. And so maybe you could share with us, what was that journey you had to establish Lifebank, and what does it address?
Thank you. A great question. And like you said, I think many of us on this panel, our work started with a personal story, a personal connection to the problem. And I am not any different. 10 years ago, I have a great 10-year-old. So while I was giving birth to him, I had a very difficult birth. Of course, I'd been in healthcare for a very long time. I had supply chain experience, health economics experience. I'd worked with global foundations. So I had some expertise, but it was an intellectual pursuit and nothing personal at that time. And I had a baby, and I had an awakening and understanding of the personal nature of the data that I sort of like worked with every day at work. That it is actually individual people, that, you know, when we say mortality rate is this many women, those are individual women, right? And that, you know, I was quite young at the time, but it hit me, and it was a very significant change in the course of my life. And in engaging with the problem, I realized that actually, and this is what keeps me up at night, this simple solution to some of these challenges, and the fact that they are so endemic, and the fact that they continue to be a large problem, and the solution is right there, and it's very simple, always just shocks me. I always say that, how did it take me, right? I'm not very special, right? How did it take me to think about, you know what, we can actually solve this? So what is the problem? Well, you know, across the world, the largest killer of women in childbirth is postpartum hemorrhage. Mm-hmm. So she gives birth, you know, she starts bleeding, and then, you know, within 20 minutes, if it's really bad, or 2 hours, she's dead, right? She basically bleeds out. The solution is, of course, to stop the bleeding and to replace the blood she's lost. That's it. There are uterotonics, there is blood, and you need all of those supplies to be in the hospital. In the global, I remember when I started Lifebank, there was a story I read that in a particular European country, I can't quite remember it, there was no woman died in that year from childbirth. And I was just like, and at the same time, it was thousands and thousands of women in Nigeria, where I'm originally from, and across the global south. And I felt like, well, it's possible to get to zero, right? Because this is the example, and we can do the work to get to zero. So that's where my work started. And what is the problem? Blood is available somewhere in this country, right? And in the hospital where this particular woman needs it, the hospital does not have the blood that she needs. So what do we need to do? We need to build technology that connects all the blood banks, and then build the logistics, literally physical logistics. The picture that most people know about Lifebank is a red bike with a rider with a blue box, you know, moving blood up and down in major cities across Africa. And that is what we did. We literally set up the technology, got the bikes, started delivering blood 24 hours a day, 7 days a week. That was in 2016. Then we saw, well, we could do this for medical oxygen because children are dying, right? Then we set that up. Then we said, well, COVID just started, PPE, they need PPE. Then we set that up. Then we said, well, people actually need equipment. Actually, our customers then called us and said, you know what, we need pulse oximeters, we need this, we need that, can you get it for us? Then we set up a system, the same system, literally a marketplace where they can come and find what they need, and a logistics system to get that thing to them, and a payment system to make sure that there's commerce happening and that this entire process is sustainable. So we did that. Now we have multiple different types of products. We have pharmaceuticals on our product, and we can get this to communities as far as Yobe State in Nigeria, as far as Maiduguri. We're working in Ethiopia, in Kenya. We're 24 hours a day, 7 days a week. We have thousands of riders on the road delivering these critical supplies, and we are getting to scale. But it really started with a simple idea that I'm a woman, I'm on this hospital bed, I don't know whether I'm gonna live or die. But thankfully, I am in the US. I had access to all these resources that I needed. As an American, I had thousands of doctors ready to help me. There was packs and packs of blood waiting for me if I needed it. And I knew intellectually and emotionally that there are thousands of women who don't have similar access, excuse me, who don't have similar access in the country where I'm from and across the global south. And I felt like I had the intuition, the passion, the courage to try and solve this problem, and that's what we've done.
That's amazing. And the audience is going to agree with me that we have to just make one correction to what you said. You are special. And it was really, yeah. And I think that's not without reason that you were recognized yesterday by the World Economic Forum as a social innovator. So congratulations also for that.
Thank you.
Emanuele, before coming to, I just want to make sure you have a microphone on hand. Perfect. And, you know, Emanuele, when I think about your work, it demonstrates the fact that the problems that we're laying out here, the frustrations that we're talking about, are not just solved with financial resources, right? And I think your title with the word strategy impact really say a lot about what you're doing and the way you're thinking about a more strategic application of financial resources from the private sector to more impactful outcomes. So maybe you could tell us a little bit about what that looks like.
With much pleasure, and thank you very much for having the WHO Foundation here today. We are a fairly new foundation that has a very strong focus on health equity, and that is working with the World Health Organization, the largest normative agency in health, to mobilize resources to really support the people that have the courage, the passion, and the intuition to bring the solution that the world needs. And part is funding, and mobilizing funding also from places where funding may not be mobilized. We are trying to mobilize resources, private capital, that currently doesn't go much into health resources, and bringing this private capital up to invest in technologies that can actually change the lives of people on the ground for the better. We're also trying to work with philanthropists and mobilize their resources, thinking about what Luke's mentioned on climate and health. It's very true. Years and years discussing the problem, not many solutions at hand. We want to bring the solution at hand to those philanthropies that have the resources. They are ready to provide funding for solutions that can have an impact, but they don't mobilize it. Similarly, we want to bring in the private sector and also the general public. There is a big desire from a large part of the general public to donate and bring resources for causes that actually have an impact. And the spirit of solidarity is something that I personally believe very much on and can be mobilized. In terms of impact, I would like to see some shifts. And I'm going to be a bit provocative, but it is really moving from treatment to prevention. It's moving from tertiary care and investing in hospitals to primary health care. And I would say when you talk about primary health care, moving out in communities as far as you can, community health workers and health posts, and just being out there, is moving from high-income countries to low-income and middle income, is moving from men's health to women's health. And it's moving from investment on response to investments on preparedness and readiness. These are massive shifts. But if you want to have an impact on the global health, this is a shift that needs to happen. And it's political, first and foremost, and then it's linked to politics where finances are being allocated. And then within that, you can give priorities to different type of health aspects. And to me, is being scientific, going where the burden of disease is highest, is super important. But one element that has come up already several times is equity. And how do you ensure that you put, all of us, the focus on the people that are less served, the people that have been discriminated, the people that have been suffering for generations of injustice. We have 3.6 billion people that are at risk of climate consequences. These are the people that have not created the climate effects that they are going to suffer. And there is a moral imperative to work for those people. And similarly, you can, thinking about the US and why women of color die 3 times higher rate of white women, there is structural injustice that need to be fought. So we need to bring, I think, the compass, the moral compass towards equity, towards structural justice, and then mobilize resources and invest accordingly.
Thank you, Emanuele. And I think in your remarks, you're inspiring us to also now think about, after we've laid out this landscape of issues, of frustrations, areas that we need to focus on, I know you're all at the same time thinking very much about the how and how to affect change in this area. And I'm going to ask each of you a question now to give us a flavor about what that how looks like. And Megan, maybe I'll just ask you, after hearing about all these staggering statistics, a very simple question. What do we need to do that women are taken in health more seriously?
Well, there's a lot to do. I mean, I think you mentioned, right, what's the big idea? I think the big idea, as we were talking about here, is it's not hard. In the sense of it's not like we need some fancy generative AI tool that's going to somehow intervene. It's basics, right? So if I would say what's the near-term things I would like to see, is I would like to see medical education to include the differences, the biological differences between men and women in their curriculum. We don't need textbooks that have all white male anatomy, and then we have maybe in a footnote, if we're lucky, that sometimes it presents differently in women. And of course, we need to also highlight intersectionality, right? The gender is just one piece of it. The second thing is we need to educate the population. Many of you probably are not familiar with these statistics, and we're talking to the people that are closest to healthcare. It's just staggering the lack of education and understanding. We need to destigmatize these terms, right? Menopause, endometriosis, sexual reproductive health. This is half the population, this is their daily life, but yet we're still afraid to talk about it. So I'd love to see education and awareness. We're starting to see that with menopause, for example, this past year. It feels like we're finally having a breakout moment, which we're very excited about, but we have a long way to go on everything else. So I'd like to see us do big awareness campaigns and particularly help girls. We need to be able that they need to be educated about their own bodies. They need to understand the biology. They need to understand how to be empowered to ask the questions, and make sure that they're prepared to deal with the biases that they face when they go see physicians and they don't get taken seriously because their pain, oh, it's just a thing. It's period pain, or it's just hallucination. No, they need to understand that that's a structural situation and they have the right to get the care that they need.
Okay, thank you, Megan. Ernest, I think what was exciting in the journey of BroadReach was that you recognized along the way that good ideas can be facilitated through technology, and BroadReach pivoted in a way to become a kind of tech innovator as well. So how are you making that happen? Maybe you could tell us a little bit about that.
Yeah, sure. So I think first for us is using data and intelligence from the data to make those statistics that Temie spoke about identifiable, right? Because when you don't make them identifiable, you end up with what I call butter on the bread approaches. You can't quantify who they are, where they are, what's going on with them. So your scarce resources, you try to spread them as evenly as possible, and you end up with a lot of resources in places they don't really need to be, right? And so from an allocative efficiency point of view, but also from a focusing your scarce resource for maximum impact, you need data down to the individual level. So everybody must be identifiable. But in the spirit of also now flipping things around to actually improve the model, instead of waiting for you to get sick, let's take accountability for you from the very beginning to the very end as an identifiable individual, right? Where at every point in your life, every age, every milestone, we're maximizing all the wellness interventions, whether it's vaccinations, certain screenings that are required. And if you map that out across, and we know this is what maximizes your wellness, it's good business for health. So for example, you'll be immunizing more kids. People who sell immunizations will make more money, right? But right now, they're usually focusing on a little tiny sliver of the market that is actually accessible. And then you pair that knowledge, even if these people are on the periphery, people like Temie have the answers for how you actually deliver it to them, right? We have a whole bunch of answers for how you actually deliver it, perhaps the last mile. So I think for me, that's one, this kind of almost like I call it full life cycle accountability model. The second one that I would like to introduce is, one second. I can barely keep two things in my brain after having multiple bouts of COVID. It's the institutionalization of partnerships as the de facto model through which we deliver, in particular, scale up of innovative health programs, as opposed to the exception. And right now, there's this feeling, again, that it should belong to government. Temie, if you were in South Africa right now, you know what the conversation would be? You need to hand that program to government to do, right? That's kind of the mindset. So to me, public-private partnerships or partnerships between the state and non-state actors who have the solutions, it becomes the default model. It is okay for her to scale. It is okay for her to become a $3 billion company. There's nothing wrong with that, right? And that as a long-term mechanism of how we achieve sustainability. So to me, sustainability is not, the answer isn't government, the answer is long-term, trust-based, productive, and accountable partnerships that actually consistently deliver results. And if they don't deliver results, you switch out those players to have people who are always hitting the mark and delivering the required results.
Thank you, Ernest. And interesting once again that you mention in your closing remark about two things I think Lutz would also like to speak about in terms of that intersection between data and sustainability, because Lutz, I know in your work you're a strong believer that data can make our future more sustainable. And I almost wish we had a way to have a lens to look in the laboratories of Novartis from here, because you would find that it's not just medicines, but a wide range of innovations and technologies that are also being applied to improving access to health, including artificial intelligence. So contrary to maybe the report that came out from the IMF, which engendered a sense of fear, you see opportunity in that.
Yep.
So how do you see that shaping?
No, there are certainly tremendous opportunities, and I think it also became clear here during the week. What I'm always a bit skeptical is if you identify a problem and then immediately you say, well, AI is going to solve that for us. I don't think it is that simple. But I think first, let me build on what you said, Ernest. I think we need to reframe health not as an expense, but as an investment.
Exactly.
And then when you invest, you want to be very precise where you invest. And we all have scarce resources, and that is, from a public health perspective, in my mind, where data can really help. And it was actually last year in this very dome here that our foundation had a session very similar to this one here on using data, digital, and artificial intelligence to decipher the social determinants of health in partnership, public-private partnership, with a number of city governments, including the city of New York, where we are using all the data that exists, very often fragmented, very often in silos, and together with Microsoft, try to use computing power in order to make sense out of all these fragmented data and help governments in their investment choices, with the hope that a lot of it will be preventive investment rather than just caring after the sick. But then, as you said, there is, of course, a lot more that data, digital, and technology can enable. And indeed, we use data across the entire value chain. It can help with identifying targets for which you design new molecules. It can help making your clinical trials more efficient. It helps a lot in your supply chain, making sure the medicine is at the right place at the right time. And ultimately, I believe that if being used carefully, that technology can help, but we need to identify the problem first. We need to have the will to work, utilize data, digital, and technology, and we cannot just sort of hail it as the panacea that's going to solve all our problems.
Thank you, Lutz. And I think alongside data, digital, Monique, there's also this element of, if you will, kind of small tweaks to the system. And I know you think a lot about that too, and much like Temie have looked at certain phenomena and think that this is also fixable, right? And whether it's delivery of healthcare to women in prison systems, or so, what are some of these things that you feel are the how, and we're going to achieve change?
Well, thank you for that. I think it really incorporates a good deal of what folks have said here, you know, whether it is looking at health literacy campaigns. I mean, I think that we can take that idea and expand upon that, because who doesn't know about breast cancer at this point? Who doesn't know someone who's had breast cancer and hasn't been affected? But there are issues regarding the guidelines, which are rather confusing. Is it every year? Is it every other year? Is it 6 months if you have some history? So there's a lot of misinformation, and I think there is room to to really expand upon the health literacy campaigns and then extend those into action, which, WHO Foundation's done an amazing job of activating in Zimbabwe in prisons and screening a population of women who perhaps have never been screened. In the United States, less than 40% of incarcerated women have had a mammogram in the last 2 years, and 88% of them would like one when surveyed. And so there's an opportunity to provide these sort of implementations, if you will, these transactions and activations, things like More Than Just Words with Novartis in cities like Atlanta and cities like Dallas. But moving beyond that, really to reimagining what these private and public partnerships can look like from a different perspective, beginning with the end in mind so that it's not transactional, but it's an end to never end experience. And what happens is it frees you up from the ideology of a single technology as a solution to committed to finding a solution for a problem we're all now unified around. So we have the opportunity to explore different technologies and to try a thing and not just try it and say, well, you know what, it worked, and we pack up and we leave that community where we then breach the trust because we've left that community in the lurch. But we can begin to establish some partnerships that are a bit more sustainable by beginning with that end in mind. And to your point really about the moral compass of this, when you get down to the data surrounding things like breast cancer, if 93% of women around the globe will not ever have a mammogram, what do we reprimand them to? What do we offer them besides a clinical breast exam, which is woefully inferior? Flip a coin odds of finding something. And so that sense of moral imperative should galvanize us to really find some solutions. And I'm speaking very breast specific because I'm pretty passionate about it. But in every sector, we can then work with social entrepreneurs. We can work with innovators. We can work with bio and pharma and tech, and we can work with our foundations and really provide some sustainable solutions when we adopt that sort of end to never end model that is not just transactional because, oh, we just want to see a little bit because we're trying to bridge that trust gap. Well, trust is a feeling, and trust comes from relationship. And trust comes from people. And so having those relationships and building them, building that trust will allow us to then innovate in markets that we have not been able to reach heretofore. And I think that's a possible desire for Bexa. It's one thing that we really are working towards is building those relationships in a very sustainable fashion as opposed to the transactional model.
Okay, thank you, Monique. Temie, I think part of the how is scalability, right? Mm-hmm. And you live in Africa's most populous nation, and I'm sure it wasn't just a walk through the park in terms of, and Ernest also spoke to the kinds of reactions you may encounter in other geographies, right, if you come with such an idea. So how did you do it? And what's your recommendation and advice to others to scale such a solution as Lifebank?
I like to call myself a happy warrior, right? I like to make sure that I infuse my life with joy and grace, but at the same time know that I'm essentially fighting on behalf of our patients, right? And fighting different people who just don't get it, right? I've had to, push governments and push regulators and push, even the global health community. Find it difficult to know what to do with Lifebank, right? Not you guys, of course. But find it difficult to know what to do with Lifebank. Here is a business. We do make money. We do charge, right? We want to be financially sustainable. We think profit is not a dirty word. And at the same time, impact is all we think about every day. And it's very difficult for the global health community to take that and think, are you NGO? I mean, folks would tell me, why don't you just set up as an NGO? And why don't you just, but for me, I think the model that we have is the right model, right? And what is so interesting about the scale we're trying to get is that we have figured out a way, right? It's not a novel way, but I think we've taken this idea and run with it about a cross-subsidization as a way of being profitable and sustainable and impactful for the most poor. So what does cross-subsidization mean? Essentially, if I go to Lagos, to Nairobi, to big cities, and there are people who have the resources, right? I charge them, right? I charge them very well, right? Then I take the savings that I get from charging those people, I make sure that I'm subsidizing, health posts in the villages, so that same supply chain, that same innovation, that same excellence can be taken from the Lagos, right, all the way to a tiny village in a tiny state, right, into a tiny health post. And I think that's the interesting thing about what we've been able to do, right? And that's why we're comfortable with it. So for example, and we have to build technology to make this happen. One of the technologies that I'm so in love with that we built ourselves is something called Smart Access. It is essentially using blockchain to guarantee this crop subsidization and to make sure that when institution like major pharmaceutical institution want to get access price medicines to the last mile, we can allow them to get that access price to the last mile, at the same time bring the pure commercial play to the same market, right? To different parts of that market. So if you want to sell to large private hospitals the same product at a profitable price, we give you this, we use a blockchain technology to track the supply chain of that particular medicine. And at the same time, if you want to make sure that this same medicine, this same initiative gets to the last mile at an access price, so you're not reducing it, you're subsidizing it, we give you blockchain to protect that market size as well. So I say all of this to say that we every day think about the technology, the innovation that will, one, guarantee scale. And when you're thinking scale, to your point, when you're thinking scale in Africa, you have to think of everybody, right? It's not just the Lagosians and the people in Accra. You have to think about people in the villages. And that is what's going to get you to scale. And if you're an innovative business, you have to think about how you're going to make sure that they can afford what you are selling. And the way we've been able to get that done is to say, okay, cross-subsidization is our financial model, right? Is our pricing model. It feeds into everything that we do to make sure that, one, we're getting access to the right people, but two, we're doing that sustainably, long-term, that there is no way now that Lifebank could, I'm not very good at asking people for money, so I have to make sure that I build something that is sustainable inherently. So for us, is to take this idea that we've ironed out over 8 years in Nigeria, in Kenya, and in Ethiopia, right? And take it to the rest of the global south, right? And which is why I'm showing up in this kind of platforms to say, okay, what are the partnerships? What are the opportunities? We've built this road, right? Digital infrastructure and physical infrastructure that allows innovation, that allows products, that allows any type of product, whether cold chain, whether normal chain, that allows it to get to the very last mile. So now we've built it, we've shown that it's profitable, we've shown that it can work. Now we need to scale it to the rest of the world.
Thank you. And, Emanuele, hearing Temie's remarks makes me think that scaling is something very challenging, but can also be very inspiring to work on. But we know that the field of areas that need to be addressed are equally large. The WHO Foundation has had a focus, amongst other things, on pandemics. You did a lot during the COVID-19 pandemic, on Ebola. But you also think about things like mental health. And so how do we get equity to work across a wide range of health topics?
Thank you. Rao gave us the suggestion when we started. You can do as politicians do, don't answer the question. So I'm taking the liberty to take a little bit of a longer route because I wanted to go back to Temie's, because I think what the model that she's expressing is a winning model that needs to be replicated with resources that come from some parts in the world. The WHO Foundation launched at the UNGA a Global Health Equity Fund, which is a fund, $200 million, we're still fundraising for, that should support innovators and technologies, particularly in operating in middle-income countries, to expand and go to scale. And what we have built into this equity fund is that whatever company will be financed, this company will have to sign an access pledge that will make sure that the products will then be made available also in areas that where that may be more difficult. And the cross-subsidization point that you were bringing forward speaks exactly to that. So for me, this is one, and we should be talking afterwards, because that could be a potential entry point. But in mobilizing private capital with the understanding that you can actually marry financial return and impact, health impact. That is transformative, and that should be incentivized. And then on the other hand is working with governments to make sure that this can thrive in an environment that allows public and private partnerships to flourish. And on that, one of the things that we as an organization are trying to do is ensure that the WHO, which is the organization that provides the normative guidelines that then are used across the world, that provide the technical assistance to governments, is financed in a way that is adequate, which has not been the case over time, and pending a decision by the executive board at the end of the month, the WHO will have the very first investment round by the end of the year, in which we will be trying as the foundation to bring together the philanthropies, the private sector, to really finance an organization that has been inadequately financed for the scope of the world. Basically, the budget of the WHO is one hospital in the US. You can imagine the challenge to bring this enormous agenda forward. But these are the type of models that we should be fully supporting and ensuring that countries can really welcome and let them exponentially grow, and then from country moving to other countries, to other regions, for maximum impact. So very, very inspiring.
No, thank you very much, Emanuele. We have now just a few remaining minutes, and I would like to turn to the audience. I'm sure you're brimming with inspiration after hearing our panel. If you would like to ask a question, I just ask you to raise your hand, stand and state your name and organization, as well as your question. Anyone like to pose one? Back, please.
Hello, I'm Carolyn Shao. I'm a physician with Fraser Health in Canada. And to your point, I would say that the system also does not work in Canada either. But we have for many years invested in an institutional-based system that prioritizes treatment instead of prevention. Do you have a proposal of what we could do differently in the context of thinking about, if I could, in my institution, in a high-income country, if I could offload some of the work of my skilled workers to technology or something else, I could make that pool of skilled workers available, or available to other countries that may be able to benefit from those resources. Just any ideas about how we go about doing that?
Would you like to take that?
Yeah, I'm happy to take a first shot at it. I mean, I think some of the challenges actually in the global north are not that fundamentally different from what we see in the global south. And if you see, there's a shortage of physicians everywhere in the world, and there is non-physician healthcare workers who I believe can potentially make a huge contribution. And whether that is the community pharmacy in, say, Northern America and the community healthcare worker in sub-Saharan Africa, the idea still is the same. And I think what we need is to allow the health systems to develop a little bit of breathing room so that eventually then we can make that shift from essentially only looking after the sick to doing more preventative medicine. I think that data and digital technology, and we saw that during the pandemic, where we had sort of online consultations, where you have potentially an algorithm that helps you lead or identify those patients that really need expert advice relative to those that need general advice. But I'm also hopeful about some of the medicinal technologies, for instance, the mRNA technology, where hopefully if deployed at scale, and I find that really fascinating, you could, that's the vision at least, with a once annual injection, you could control your cholesterinemia, you could control your hypertension, and essentially you don't need as a physician to see that patient on a monthly or bi-monthly basis in order to guide that patient. So I think technology, both in data and digital, but also true new scientific inventions, are going to hopefully reduce the burden on the current health systems in order to generate that sort of spare capacity to pivot into a more preventative medicine system.
Monique, I think you were eager to also lend a remark. We have maybe about 30 seconds, so if I could get you to...
It can be done, and it can be done in early detection. And one of the things that we've done at Bexa and we're really excited about is implementing AI into the technology to allow for the looming physician shortage so that we can then train community health workers to do breast exams and enter into markets where physician shortage is real, where there may not be healthcare workers. We can then use that to partner to collect data and enroll patients in clinical trials. And so there are these opportunities for partnerships when you have women that are willing to adopt a technology and willing to pursue it, and when you have the opportunity to enter into these markets with technology. And this is the exciting part of the answer to your question. There is excitement, there is hope. There is optimism through that partnership and through the use of technology to promote health equity as a commodity. I think that and as a moral imperative is huge, and that opportunity is here and it's now.
Thank you so much, Monique. And I think there couldn't be a better way to close the session. And I think this is very much the spirit of Davos, that we're not only talking and stating issues and problems, but really thinking about ways to address them concretely. And to build the coalitions. And I'm very much looking forward to carrying the conversation forward and to seeing you next year. And I wish you a rest of the week, a lot of success. Thank you.
Thank you.